evening, ladies and gentlemen. We are about to begin this evening's session, so we would like you to have an enjoyable session. Please sign in with your full name, first and last. To make any changes, you just right-click on your name, and any necessary changes can be made there. Lastly, we would like to inform you that this event is being recorded for storage and archives. Therefore, to ensure the integrity of our production, we kindly ask for your audio and video functions to be turned off at this time. Thank you once again for joining us. I will be your host for this session. So good evening once again, and a special warm welcome to our specially invited guests and the colleagues from the Mona and KFL campuses. I am Vanessa Ramsaran, President of the Pathology Club of UWI. I would like to thank you for joining us for what is to be our 23rd installment of CPALMSI, and this is actually the last CPALMSI session for the 2022-2023 academic calendar. So we've been quite productive this year. So now I'd just like to introduce our speaker, Dr. James Farmer. I'm very privileged to be introducing someone of his status. He will be sharing his wealth of experience and passion for pathology in a 45-minute overview of ophthalmic pathology. But before we begin, I would just like to give a brief background about him. Dr. James Farmer, MD, FRCSC, FRCPC. He's a Canadian board certified in ophthalmology and double board certified US and Canadian in anatomical pathology, an adjunct associate professor, Department of Ophthalmology and Department of Molecular and Laboratory Medicine, Queen's University, Assistant Professor, Department of Pathology and Laboratory Medicine and Department of Ophthalmology, University of Ottawa. Hold on to your seats, there is still more. Current President of the Canadian Ophthalmic Pathology Society and Ocular Pathology Section Editor, Canadian Journal of Ophthalmic Pathology. So a very impressive resume there. We are all honored, pleased, and privileged for him to be here with us this evening. So ladies and gentlemen, I ask where you are to welcome the very knowledgeable and certainly most passionate Dr. James Farmer.
Well, thank you very much, Vanessa. That's a very kind introduction. And I'd like to thank Dr. Walker for asking me to participate. It's always nice to share my experiences in ophthalmic pathology, which is a niche subspecialty of both ophthalmology, but primarily now pathology. So I'd like to title this talk, Ophthalmic Pathology, Putting Ophthalmology Under the Microscope. This also happens to be the title of our current, or upcoming, Canadian Ophthalmic Pathology Society meeting, which is in June. We hold it in conjunction with the Canadian Ophthalmological Society annual meeting. We invite papers from oculoplastic surgery, cornea and external disease, my ocular pathology colleagues, usually presented by residents. We have about 25 cases a day. We have an invited guest speaker from the United States or Europe. It's quite an impressive performance. And anybody who's interested in something like that going forward, we're going to try to expand to include anatomic pathology residents who are interested. As I get older, I'm often accused of not hearing things. So I sort of decided that I would kind of look for a hearing aid. And I came across this and I thought, this is the kind of hearing aid I want, which is special. It filters out criticism and amplifies compliments. So this is a picture of an ocular fundus or a retinal photograph that is out of focus. It's out of focus because there's pathology causing the picture to be out of focus. It's in the vitreous. I will go over the pathology of this later, but this is where ophthalmic pathology shines in making a diagnosis of this patient's problem. So what is ophthalmic pathology? It is a subspecialty of anatomic pathology that renders diagnostic interpretation of specimens from the eyelids and periorbital skin, conjunctiva, cornea, and sclera, intraocular tissues, which include lens, the vitreous cavity, the uveal tract, which consists of the iris, ciliary body, and choroid, the retina, also the optic nerve, and then orbital structures, which include the lacrimal gland. So to start off with a little bit of the lay of the land, I don't know if you can see my arrow on the picture, I hope so, but this is a good picture of the ocular adnexa, which is the tissue that surrounds the globe in the orbit. And as an ocular pathologist, we will get specimens from all of these particular areas: eyebrow, the eyelids, the lacrimal gland. This is set a little bit back into the orbit. I'll show you a little bit more about these meibomian glands in the eyelid itself. This also orients you a little bit to the extraocular muscles. There are 6 of them, but these are just 2. The lacrimal drainage system is why when you cry, your nose runs, because the tears drain into these 2 little holes in the medial area of the eyelid called the medial canthus. And these little canaliculi take this into a thing called the lacrimal sac, which empties into the middle meatus of the nose. So if you actually cry and nose runs, you know your lacrimal drainage system is working fine. But inflammations and tumefactions can occur at all of these particular sites, and that ultimately is the purview of ophthalmic pathology. If we take a little bit more into the histology of the normal eyelid, you can see that it is different than what you would expect in skin dermatology, for example. And so I'll just go through this because some of the diseases I'm going to illustrate a little bit later. And really the thing that makes ophthalmic pathology unique in a way is this structure that is on the surface of the eye and the ocular adnexa called the eyelid. The eyelid, starting from the skin surface, contains epidermis and dermis, a little bit of subcutaneous tissue, the orbicularis oculi muscle, which closes our eye. That includes pilosebaceous units. The sebaceous gland associated with the hair follicle or the lash follicle is called the gland of Zeiss, which is important. Once you go deep to this, you come into the rubbery tissue that supports the eyelid. It's the firm part of our eyelid. It's called the tarsal plate. It's elastic tissue and fibrous tissue in which are embedded meibomian glands. These are these sebaceous glands that extend basically the length of the tarsal plate. There are 28 in the upper eyelid and 26 in the lower eyelid. Their function is to secrete an oily material that is part of the tear film. And the reason we're able to lubricate our eye and keep the lacrimal gland secretion, which is very aqueous, onto the surface is to have a good meibomian gland function. There are diseases that are associated with rupture of these meibomian glands, and one of the carcinomas that I'll show you a little bit later that is one of the purviews, again, of ocular pathology, sebaceous carcinoma, most commonly arises in the meibomian glands. When we get closer then to the inner surface of the eyelid, it is lined by conjunctival epithelium. Conjunctival epithelium is a pseudocolumnar epithelium with goblet cells. And it has it's usually flat. This is a little bit inflamed with a papillary pattern, but the goblet cells contain the basal layer of our tear film that, again, the other aqueous and the lipid layer sort of rest on top of. The gland of Wolfring is an accessory lacrimal gland that is found in the tarsal plate. So this is a good cross-section of an eyelid. If we look at the globe, just to make you familiar, I'm sure you all remember this from med school, but we'll refresh it a little bit because of the pathology I will illustrate as we go through the evening. We start at the front of the eye, which is the cornea, the clear structure that light initially it goes through. It then joins at the limbus into the white, tough outer coating of the eye called the sclera, which is right around here. This is the corneal scleral limbus. We'll talk a little bit about that again going forward. When we go through the cornea, this open space between the cornea and the iris is called the anterior chamber. And the anterior chamber contains aqueous, which is produced in the ciliary body, flows around the lens through the pupil and drains at the anterior chamber angle. If any of your family members or unfortunately you have a problem with glaucoma, the pathology of glaucoma actually, for the majority of cases, lies in the anterior chamber angle and a compression of the normal sieve-like meshwork called the trabecular meshwork, where fluid eventually drains into aqueous connector channels, then into episcleral veins. Once we go by the iris, which is the anterior part of the uveal tract, we come into the posterior chamber, which I already talked about. The lens is suspended by the zonules, from the ciliary body. The ciliary body is the next portion of the uveal tract. And then going posteriorly, we have the vitreous cavity, which is a gel-like material that, as we all mature gracefully, liquefies, undergoes a process called protein syneresis. So that's why, as you have heard, I'm sure your older colleagues, parents talk about floaters, that is the degeneration of the vitreous cavity, which is a normal process of aging. The inner layer of the eye is the retina. That's the neurosensory portion that contains the photoreceptors that then transmit the signals chemically through the ganglion cells. The ganglion cells form the optic nerve, which is a tract of the brain. The tissue right below the retina is the third part of the uveal tract, or the choroid. It's the vascular layer which nourishes the outer part of the retina. And then, of course, we have the optic disc, which is the surface of the optic nerve seen in the eye. And then we have the optic nerve itself. So this is the basic structure of the globe. What we see on enucleations is this actual structure. So this is the cornea, as we talked about. The pupil is the space in the middle of where the iris is. The limbus is the junction of the cornea and the sclera. It plays an important role because the stem cells that form corneal epithelium reside in the limbus. If you've ever had a corneal abrasion or a scratch, these limbus stem cells become very important because they help to migrate into where the defect is to help to cover the wound, so to speak. These are the different extraocular muscles: superior rectus, the superior oblique, medial rectus, lateral rectus, inferior rectus, and then these would be just the vascular arcades on the episcleral portion of the eye. The sclera itself is avascular. The episclera is the vascular tissue just anterior to it. When we section an eye, and we usually do it in a 3 to 9 o'clock fashion, so we can include part of the macula, which is the center part of the retina, this is what we see on cross-section, where again, we have cornea, the anterior chamber, we have the iris, this is lens, ciliary body, vitreous cavity, the retina, the choroid. This is a good example of a choroidal tumor, a choroidal melanoma, which we'll talk about a little bit later. If anybody has any questions or anything, please don't hesitate to shout them out. I may not see it if you raise your hand, so I'll try to give enough time if people want to say anything that they've got time to contribute. This is a histologic section of an eye, similar to the one that we just saw. And again, one can see the structures a little bit better with this is the cornea. Cornea has 5 layers, not important for you to know them all at this point, but the epithelium's on the surface, the endothelium lines the inner surface, anterior chamber, the iris with the iris pigment epithelium, which is part of the original optic cup in embryology. This is the lens. The suspensory ligaments are usually gone when we do sectioning. This is the ciliary body here. And then this is the retina. And this is the choroid. This is probably an artifactual retinal detachment. When we look at globes enucleated for tumors or for blind, painful eyes, we can tell by the appearance of the photoreceptors whether this is a chronic or true retinal detachment or if it's an artifact of sectioning. And then this, of course, is the optic nerve head, and this is the optic nerve. So this is just a general picture of what we see when we actually section an eye and submit it for tissue processing. So what is ophthalmic pathology? Well, first, it's a beautiful blend of clinical and pathologic correlation. My career started out as an ophthalmologist, and I was practicing that for about 4 years before I went back and did my anatomic pathology residency. People were wondering, why would you do pathology when you're an ophthalmologist? Well, if you extend a slit lamp, which is what this young physician is using to examine this lovely young lady, it's just a horizontally mounted microscope. Ophthalmology and pathology are two very unique specialties in that we see again, a little bit like forensics as well, with courtesy to Dr. Walker, we see what we diagnose. So when I have patients at the slit lamp, I'm looking at all the ocular adnexa, the cornea and everything. I can make many, many diagnoses clinically based on the use of this horizontally mounted biomicroscope. If you just take it one step further to our colleague here, which is the conventional microscope that we all use in pathology, it's not such a stretch to think you're going from this to this. And again, we are fortunate in that as ophthalmologists, we see what we diagnose, and pathologists, we see what we diagnose. Ophthalmic pathology also is unique for some examination techniques, which you don't characteristically use in other areas of pathology. This is transillumination. When a patient has an eye tumor, intraocular tumor, in adults most commonly uveal melanoma, it's important when we go to process the specimen to determine what the maximum tumor diameter is attached to the sclera and the maximum thickness. So we have to be able to localize in the globe where the tumor is. And we use a transilluminator in through the pupil, and you can see that it transilluminates well, except where there's a tumor. So we transilluminate the globe, we mark it with a pen, and then we section it through the peak of this to be able to get this cross section, which will give me the maximum basal diameter and the maximum height, which are the two features we use to give a T-score for the tumor. What is ophthalmic pathology? It's also a beautiful blend of dermatopathology, soft tissue pathology, head and neck pathology, hematopathology, neuropathology, but we're different. And what I hope to do in the next 45 minutes or so to an hour is to go through the spectrum of ophthalmic pathology, show you what we look at and see and can diagnose. And if any of you are writing your American board exams, some of these topics will come up on your American boards. So might be a little bit of a refresher as well for some of the topics I'm going to talk about. So we have a case here of a patient presenting with a bilateral granulomatous uveitis, which is an inflammation in the uveal tract. Usually, if it's anterior, it involves the iris and ciliary body. If it's posterior, it involves the choroid. And then this patient also has these yellowish nodules in the inferior tarsal plate area and in the fornix. The fornix is the area of the conjunctiva where the conjunctiva reflects from the surface of the globe, called the bulbar conjunctiva, onto the eyelid, which is called then the tarsal conjunctiva. The patient has chest imaging done, and they find bilateral hilar lymphadenopathy. This picture is the slit lamp view, and all these little white dots are granulomas that are adherent to the posterior corneal surface. And although it's a little tough in this picture to see, if you were to look here, you would see little white specks floating in what looks like a film. We call that cells and flare in ophthalmology, and those are the characteristics of a uveitis. So the diagnosis is sarcoidosis. Sarcoidosis, you're aware, is a multisystem granulomatous disease of unknown etiology. The saying in ophthalmology is that if you know sarcoidosis, you know ophthalmology, because it can affect every structure in the adnexa, into the orbit, optic nerve, and it presents an interesting differential. The conjunctival granulomas are these yellowish bumps that I have illustrated here. The uveitis with these granulomas on the endothelial surface, and they can actually occur on the iris surface with specific names. That's a granulomatous anterior uveitis. If there's inflammation in the vitreous, we call that an intermediate uveitis. And then if we go a little bit further, you get some of these white spots, which can actually be in the choroid as part of a posterior uveitis. They can also occur more superficially in the retina as retinal granulomas. It can inflame the optic nerve head and give a condition that looks a lot like papilledema with a little hemorrhage. That's an optic papillitis. And then it's well known to involve the lacrimal glands, with unilateral or bilateral lacrimal gland involvement, and it can cause double vision when it affects the extraocular muscles and patients can't move their eyes in certain directions. So again, sarcoidosis affects many different parts of the eye. I'm sure all the pathology residents here are very familiar with what sarcoidal granulomas are like. They're non-necrotizing, discrete. You'll see them in the substantia propria of the conjunctiva. And back when I was training as an ophthalmology resident, we used to be consulted by respirology. This is many, many years ago, before the advent of fancy CTs and things, to do blind biopsies of the conjunctiva fornix, looking for granulomas to help make a diagnosis. These were even the days before the blood tests that we can do nowadays for sarcoidosis. So 25% of blind biopsies of the conjunctiva would yield these discrete granulomas, which then would be interpreted as diagnostic for granulomas, diagnostic for sarcoid. The typical granuloma giant cell that one sees is the Langhans giant cell, but we are all familiar that this is not specific for sarcoidosis because it can occur in any granulomatous inflammation. The granulomas on the pupillary margin are called a Kepi nodule, and the stroma are called a Busacca nodule. So we have another patient who presents with a large lump on the left upper eyelid that's been present for 2 months and seems to be getting bigger. I wouldn't be surprised if any of you might have had one of these, either as a child or as one matures gracefully. This is a chalazion. A chalazion is a lipogranulomatous inflammation in the tarsal plate conjunctival area due to a rupture of the meibomian glands and the surrounding granulomatous inflammatory response. These are very common. Clinically, we see these, I would see 10, 15 a week when I was busy in my clinic. We usually treat them conservatively with hot compresses. They're not infective, so they really don't need antibiotics. If they don't respond, then they come to curetting, and that's where we will get these samples in pathology. And I always tell my colleagues that if you get curettings from an ophthalmologist and the diagnosis is chalazion or chalazion, and you have on your slide a granulomatous reaction, I do not order special stains for fungi and acid fast because the clinicians know what it is. So I don't prolong the agony, so to speak, by researching the condition that is well known to be in the location and with a very specific clinical pathologic correlate. I bring up for interest this so-called marginal chalazion or chalazion. This is a rupture of the meibomian gland of the eyelash follicle. Remember we talked about the gland of Zeiss? It will create a bump on the eyelid margin. And certainly in Canada, that bump is often misinterpreted as a basal cell carcinoma because it's right along the lid margin. It's non-inflamed, kind of like a pearly nodule. So I also tell my colleagues that if the diagnosis is basal cell carcinoma and it's on the eyelid margin near the eyelashes and it's got a lipogranulomatous inflammation, I don't necessarily spend a lot of time doing extra levels looking for something like a basal cell because a marginal chalazion is in the differential diagnosis of a basal cell carcinoma in that location. But this is a chalazion, a very common thing that we see. So this patient has had a lesion on the right lower eyelid for 9 months. This is a pretty classic example of a basal cell carcinoma. Again, with the sun exposure that we have, certainly in Canada, I imagine similar to Caribbean, we see many, many of these in our patients. You are all familiar with the pathology of a basal cell carcinoma. It's a proliferation of basaloid cells, usually arising from the epidermis, descending into the dermis in an infiltrative pattern. The nests show peripheral palisading. There is abundant mitoses and apoptosis, and there is a fibromucinous stromal reaction, which when processing often gives that stromal retraction artifact. The most common form is the nodular. That's the one that is least likely to recur and is most often cured with excision, even if the margins are positive because of inflammation. But the superficial, which is down in this area here, and certainly the sclerosing or infiltrative and morphiiform types are much more likely to recur because they're less well defined clinically, so the margins are often positive. And especially in the sclerosing and morpheaform, it does have a tendency to go to nerves. And when it goes to nerves on the face, that's a sign of recurrence. But also, especially more with squamous carcinomas and basal cell, if it gets into the nerves of the face, it can track into the intracranial cavity via the cavernous sinus. So that's another concern for perineural invasion in some of these relatively benign carcinomas of the skin. So this patient was seen in the local emergency room with a lump on the left upper eyelid that was originally diagnosed as a chalazion and was treated with cephalosporin, 250 milligrams, QID for 10 days, which is a very common treatment for soft tissue or chalazia, for example, in Canada, for example. We don't see as much MRSA as they would in the United States, so Keflex or ampicillin works quite well. But it never really got better, and the patient went back and stated that it's getting bigger. The diagnosis here is sebaceous carcinoma. If you look at the clinical picture, one thing that would have made the clinician had been an ophthalmologist who'd seen the patient first, probably twigged to this not being a typical chalazion, is this very multinodular yellowish appearance. This is very typical for sebaceous lesions that occur on the eyelid. So it is the sebaceous carcinoma most commonly arises, as I mentioned, in the meibomian glands, but can occur in the glands of Zeiss as well. It forms a nodular mass in the dermis if it's a gland of Zeiss, or in the tarsal plate. The tumor cells have a microvesicular foamy cytoplasm. And you can see the very nice foamy kind of cytoplasm here. Numerous mitotic figures. The sebaceous carcinoma is prone to pagetoid spread, and that's a very important diagnostic feature in this cancer. It goes onto the conjunctival surface when it's coming from the meibomian glands, and it will go into the epidermis when it occurs in the glands of Zeiss, or sometimes even in the meibomian glands. And you all are very familiar, I'm sure, with pagetoid spread being disseminated intraepithelial spread of malignant cells. Now, to the year 2023, the diagnosis of sebaceous carcinoma is pretty much an old school cytomorphologic diagnosis. Immunostains can be very misleading, and there is no slam dunk immunostain for sebaceous carcinoma. You will read about adipofillin. Adipofillin stains fat, and it was hoped to be the answer. But the time when you need the adipofillin to make a diagnosis of sebaceous carcinoma is when the tumor is more poorly differentiated, when there's less fat in it. And when you go into your differential, which is a basal cell with sebaceous differentiation and a squamous cell carcinoma with sebaceous differentiation, you know that there can be adipofillin staining in squamous carcinoma. It's not microvesicular, so you have to see the very small vesicles, multiple within a cytoplasm, staining around the rim to be confident that that is positive adipofillin staining. So it takes an eye and expertise to be able to interpret it. But even after having looked at probably hundreds of cases of sebaceous carcinoma and many with adipofillin, this diagnosis is made on a clinical pathologic spectrum. And most commonly, ophthalmic pathologists, if it's around the eyelid, need to weigh in on this, because I unfortunately have seen a number of misinterpretations of squamous carcinoma with sebaceous differentiation and basal cell carcinoma with sebaceous differentiation that on recurrence or on review turned out to be sebaceous carcinomas. I warn my oculoplastic colleagues that if the center where they are doesn't have an ophthalmic pathologist and they biopsy something from an upper eyelid where it is most common, and they get a diagnosis of basal cell carcinoma with sebaceous differentiation, that should be reviewed, because I would be willing to bet 9 times out of 10 that is a sebaceous carcinoma. There are basal cells with sebaceous differentiation, but they not characteristically occur on the eyelid. especially the upper eyelid. And squamous carcinomas with sebaceous differentiation, the same thing. Again, there are pure squames on the eyelid. There are more and more basal cells on the eyelid than sebaceous. But when you get this microvesicular pattern, it's nice to have EMA, for example, which is positive in this and negative in basal cell, but positive in squamous. And you have adipophilin, which can be sometimes helpful. You have BRST2. There are a number of other markers, but honestly, it comes down to an eye for what this tumor looks like. Again, you'd need to know for the American boards, for example, adipophilin and the sebaceous carcinoma. And it requires, if the old days, we used to tell the surgeons if they were worried about sebaceous carcinoma, they should submit the tissue fresh, because fresh tissue, you can actually do a fat stain, or at least if it's put in formalin and you forget to put it fresh, if you tell them that it could be sebaceous carcinoma, you can do a fat stain, not the greatest, on formalized tissue, but you can't once it's put through processing, because the series of alcohols to dehydrate it will dissolve the fat, so a fat stain is useless. But really, it's a cytomorphologic diagnosis. Adipophilin can be helpful, but really you need to have a high index of suspicion around the eye. Now, why is that? Because sebaceous carcinoma can lead to devastating consequences for the patient, including loss of the eye, and the worst possible procedure that ophthalmology does is called an exenteration, which is where they have to take all of the eye and the orbital contents out down to bone. And sebaceous carcinoma left untreated, spreading onto the conjunctiva, into the fornix, and into the orbit can often necessitate this. The other reason one needs to know about sebaceous carcinoma for a pathology resident, especially going to exam times, is its association with the Lynch syndrome, or the hereditary non-polyposis colorectal cancer syndrome, HNPCC. You know that is a disease of DNA mismatch repair genes, the MMR. It's a germline mutation in these patients, leads to microsatellite instability. We do the microsatellite instability panel with the MLH1, MSH2, MSH6, and the other one that begins with P, escaping me now. But anyways, more commonly in Muratori, it's the MLH1 and MSH2 that are positive. It's seen with patients present with multiple sebaceous neoplasms, either sebaceous adenoma or sebaceous carcinoma. But interestingly, the sebaceous carcinomas in Muratori are commonly extraocular and not ocular. As a matter of fact, in my career, I have not seen a Muratori syndrome diagnosed from an ocular sebaceous carcinoma. Ocular sebaceous adenomas, yes, but not sebaceous carcinomas. They often occur on the genital region or on the ear, for example. And then you're all aware of the colorectal carcinomas that are associated with the hereditary non-polyposis syndromes. So another tumor that is relatively uncommon in dermatopathology, but we see it not uncommonly on the eyelid. Patient has had this growth on the left upper lid for 8 months. Diagnosis is a Merkel cell carcinoma. So you know that a Merkel cell carcinoma is a primary cutaneous neuroendocrine carcinoma. It's a disease of older patients, slightly more common in men. It's often a reddish purple nodule or an indurated plaque. It has a preference for the upper eyelid, similar to sebaceous carcinoma, which has a preference for the upper eyelid. Interestingly, the Merkel cell polyomavirus is positive in up to 85% of cases. And in cases where there can be a diagnostic dilemma, there is an immunostain for the Merkel cell polyomavirus, which can be helpful. The reason this is an important tumor and why ophthalmic pathologists are very aware of this is it's a bad tumor. If you look at the prognosis, 33% recur at least once, 40% have distant metastases to the lungs, liver, bones, meninges, and brain, and 33% die of this tumor in a group of patients that are already elderly. So this is a bad actor. It's the classic dermis-based small round blue cell tumor, looking very sort of neuroblastic in its appearance, with this sort of salt and pepper kind of chromatin, high mitotic rate, abundant mitotic figures. And you are all very familiar with the the very typical CK20 perinuclear dot positivity. Neurofilament is also a very useful stain for Merkel cell carcinoma. So this is Merkel cell, something that, as I said, in the ophthalmic pathology realm, we come across not too uncommonly. So this patient presents with a chronic bilateral conjunctivitis, which is an inflammation of the conjunctiva that's been present for about 8 months, seen a number of other ophthalmologists, treated with antibiotics and topical steroids, but it just is relentless. It's not getting any better. On examination, one sees a cicatrizing or a scarring conjunctivitis, worse in the right eye. This is a connection by a scar from the tarsal conjunctiva to the bulbar conjunctiva. We call this a symblepharon. And this is very characteristic of the disease ocular cicatricial pemphigoid. It is a subtype of mucous membrane pemphigoid. It's an autoimmune blistering and scarring disorder. It can affect not only the ocular mucosa, but the oral mucosa, the genital mucosa, can affect the skin. And in the eye, it causes an asymmetric bilateral scarring conjunctivitis. If left untreated, this symblepharon slowly pulls the eyelid right up, plastered against the globe, where you lose the inferior fornix. The eyelid turns in, the eyelashes erode the cornea and cause massive problems and ultimately loss of vision. So this is a very important diagnosis in ocular pathology. And I stress very clearly to my clinical colleagues when I'm lecturing them and everything, and they're well trained, that when you suspect this disease, the diagnosis is made by immunofluorescence, direct immunofluorescence. So the tissue has to be submitted fresh. And in most labs, unless you have the pathology people taking it right from the OR, what we recommend is they put it in Michel's media, which is a hypertonic saline, so that it preserves the tissue. Then we do frozen sections and we do direct immunofluorescence. And we use IgG, IgA, C3, rarely IgM is positive, and one gets this very beautiful linear staining pattern. This is IgG, and this is IgA, that is diagnostic for ocular cicatricial pemphigoid. I asked them as well to submit an area adjacent to the scar to correlate these particular findings with what we see in the adjacent conjunctiva, which is a fibrovascular scar. It's rare, interestingly, even with active disease, to see a blister, because it is a blistering disorder, but instead we see this fibrovascular scar and this very acanthotic, squamatized conjunctival epithelium with a loss of goblet cells. Now, I really get on my clinicians about this, because if they take a piece of conjunctiva and they stick it in formalin, they ship it to me and say, rule out OCP, I'm very quick to point out that A, can't do, B, ocular cicatricial pemphigoid is like a number of autoimmune diseases that one sees, especially in dermatopathology, that exhibits a phenomenon called pathergy. Pathergy is a condition where when you biopsy a tissue, like in this area, let's say you pick this area off to the side here, if this is ocular cicatricial pemphigoid and you biopsy here, you're going to get one of these formed. The disease flares at the site of the biopsy. So I tell the clinician that you have now caused, if it's real disease, a worsening of their condition because you didn't submit the tissue properly, because I can't make a diagnosis on formalin fixed tissue. Labs have tried, I'm not sure how many are successful in doing the fluorescence on formalin tissue. We've tried at our lab, and both in Ottawa and Kingston, and it just doesn't work. So that is ocular cicatricial pemphigoid. Now we have another one here where, and this is much more common, patient presents with a growth on the surface of the eye, right eye, that seems to be enlarging. I'm sure if you look at your colleagues or people around, you will see this particular lesion. It is fairly common in the population. This is called a pterygium. So a pterygium goes along with its partner pinguecula as actinically induced lesions. A pinguecula is a nodular yellowish lesion on the bulbar conjunctiva in the nasal or temporal, medial or lateral, bulbar interpalpebral fissure conjunctiva. The difference between a pingueculum and a pterygium is the pingueculum does not extend onto the corneal surface, where a pterygium does. It's a fibrous plaque that extends onto the bulbar conjunctiva. The difference between the two lies in these things I was telling you about before called the limbal stem cells. The limbal stem cells form a bit of a barrier to things getting from the conjunctiva onto the cornea. But because of the actinically induced damage to the limbal stem cells, they fail and the conjunctival tissue is able to grow onto the corneal surface. It creates irregular astigmatism and loss of vision the closer it gets to the visual axis, which is the center part of the pupil. So these are not uncommonly removed. The typical pathology would be like that of solar elastosis in the skin, which is elastotic degeneration of the collagenous tissue in the substantia propria of the conjunctiva. Pinguecula would have no attached cornea. A pterygium will have a bit of cornea attached to it. That's how we can tell histologically the difference. So this patient's had a growth on the right eye for months. The diagnosis here clinically is ocular surface squamous neoplasia. Ocular surface squamous neoplasia is a disease of older adults. It increases in incidence towards the equator because it is induced by UVB light. Again, damage to the limbal stem cells and multiple genetic alterations then lead to squamous neoplasia. Other risk factors include HIV, and it's well known, and certainly in our ophthalmology literature, if you have OSSN presenting in some individual under 50, that should be an indication for an HIV test. In my clinical practice, because I see a lot of people who work outdoors, farmers, so to speak, if it's over the age of 45, I don't get too excited and I don't recommend an HIV test. If it's under 40, absolutely, I recommend an HIV test because I have 2 cases of young women in their 30s, both of whom had HIV-induced OSSN cancers on the surface. Xeroderma pigmentosa is an autosomal recessive condition due to a genetic defect in nucleotide excision repair of DNA. There are 7 different repair genes involved with mutations in these, and they get multiple skin cancers and OSSN. The OSSN is the clinical term because the clinician can't tell whether that's carcinoma in situ or invasive. So when we sign these things out, it goes out as conjunctival squamous intraepithelial neoplasia, or CSIN, similar to what it's graded in the cervix. It's mild if it's the lower third, it's moderate if it's the lower 2/3, it's severe if it's 75%, and it's carcinoma in situ if it's full thickness. You're very familiar with the sort of grading of these lesions. And the higher the grade, the more likely it is to progress to invasive carcinoma. This particular picture would also do for an invasive carcinoma. There are the typical or conventional one often shows keratin, so it has a whitish or leukoplakic appearance. More aggressive subtypes are the adenosquamous, which has both a malignant squamous and goblet cell component. This is a good picture of an invasive squamous carcinoma of the conjunctiva. I highlight this to both pathology residents when I'm teaching them that it can be sometimes very difficult to tell with the broad acanthosis one can see in CSIN whether there's invasion or not. To me, if I see desmoplasia in the substantia propria, which is the name for the stromal tissue of the conjunctiva, just as an aside, it's not a lamina propria because there's no muscularis mucosa. And it's not dermis because it's conjunctiva. So we call it the substantia propria or stroma. When you see desmoplasia associated with these invasive islands, it's unequivocal invasive carcinoma. So this patient presents with a pigmented lesion on the surface of the right eye. It's been present for 10 years and comes and goes. The diagnosis here is primary acquired melanosis. The pathology, just like OSSN, ocular surface squamous neoplasia, is the clinical term. Primary acquired melanosis is the clinical term for pigmented lesions on the conjunctiva that aren't nevi. Nevi have a cystic appearance. The primary acquired melanosis is a flat appearance. But again, the clinician can't tell whether it's a low-grade lesion or it's melanoma in situ or superficially invasive. So they stick with primary acquired melanosis. We use the terminology conjunctival melanocytic intraepithelial lesion, or CMIL. It's classified into low-grade, which is a non-epithelioid cell population confined to the basal layer. High-grade is where it is non-nested, a suprabasilar proliferation less than 50%, and then melanoma in situ, which is full thickness or nested with an epithelioid cytomorphology. So this clearly would be melanoma in situ. I could spend another couple of hours talking about the way ophthalmic pathology used to separately classify melanocytic lesions, and we always ran into a problem with dermatopathologists who never liked our terminology before, but we finally were able to sit down with dermatopathology and ophthalmic pathology, and we're all happy with this conjunctival melanocytic intraepithelial lesion, low-grade, high-grade, and melanoma in situ, because even a dermatopathologist can grasp what this is. And its relevance, again, is its progression into melanoma. Now, this is a very interesting case where ophthalmic pathology takes a step above. This was a patient who was involved in an injury to the eye. There was a piece of, he was moving furniture, something fell into his eye. When he showed up for examination, and the diligent ophthalmology resident pulled the eyelid down, saw this brown-black pigmented area, 5x1 in the fornix. When questioned, the patient said, oh, it must be a piece of rubber from the thing that fell. But on closer examination, it's smooth, it glistens, so there's conjunctiva around, over it, or part of it. So the patient was followed for the resolution of his injuries. This never changed. So it was decided that it should be biopsied. So this is the level of the biopsy. It went to general dermatopathology, and one can see this proliferation of melanocytes in the substantia propria with this couple of cysts here. And the diagnosis was intradermal nevus with heavy pigmentation. Again, read by a dermatopathologist. The oculoplastic surgeon asked me to review this case under the pretense, he said, this is automatically wrong because there's no dermis in the conjunctiva. So I got a chance to look at this, and I reviewed this case, and I was immediately drawn to this little nest right here. And as we went deeper into the lesion, you see these nests become more frequent. They're larger, they're epithelioid, there's scattered pigment, higher power, there's a mitotic figure. A lot of this is inflammation, and there are these nests of melanocytes around the top. This, we did an HMB45 stain, which is positive in these epithelioid-looking nests. The diagnosis is an invasive malignant melanoma arising in a compound nevus. Now, it's very unusual to have a compound nevus in the fornix. That pigmented lesion in and of itself in a 60-year-old or a 70-year-old person should automatically make the ophthalmologist suspicious that this is an invasive melanoma. But indeed, this is what this turned out to be. And very important, although a rare tumor, it's 5% of all ocular melanomas. Its incidence is increasing, and certainly during the pre-COVID years, I might see in my two practices in Kingston and Ottawa, maybe 1 or 2 a year. With COVID, and by the time we finally got back after about a year and a half, I saw 5. So again, people didn't come to get examined, but I do think there's definitely a general increase. Again, it is felt to be related to chronic solar radiation. So this could be another reason why they were seeing a driving number of these cases. The predisposing factors are CMIL, which we just talked about. 75% of melanomas arise in high grade or melanoma in situ. A small number arise in nevi. About 1 in 300 cases of nevi will develop into a melanoma, and about 18% arise de novo, just as a nodular melanoma would on the skin. But this is a pretty devastating tumor with a recurrence rate that is up to 50% after 10 years. It's regional lymph node and distant metastasis with an overall mortality of 20 to 40%. The most important histological feature is the epithelioid cell morphology, the size, the depth greater than 2 millimeters would suggest a sentinel node biopsy and likely plaque radiotherapy treatment afterwards. It's also important when we get these lesions to try to diagnose CMIL, because if there is CMIL associated with an invasive melanoma, that's an indication for topical chemotherapy because of a potential field effect in the remaining conjunctiva. This is just a good example of what an invasive melanoma would look like. So this patient presents with a 9-month history of a growth on the inner aspect of the right eye, described as a salmon patch. Now, ophthalmologists tend to have a limited vocabulary when it comes to describing things. And if you are in an institution that does do some ophthalmic pathology or has ophthalmologists submitting specimens, if you see something that comes along that says salmon patch, that is our way of saying lymphoma until proven otherwise. Because you can see it has this very fleshy, pink yellow kind of appearance to it. And so this is a good example of a conjunctival malt lymphoma. The ocular adnexal lymphomas are about 1 to 2% of all human lymphomas. They're 8% of extranodal Hodgkin's lymphomas. Hodgkin's disease in the surface of the eye is rare to almost never been reported. In the orbit, it's incredibly rare. It's a disease of people in their 6th and 7th decade. It occurs in all sites, but most commonly in the orbit, lacrimal gland, and then conjunctiva, where it presents as a salmon patch. Most often it's localized to the conjunctiva and not associated with systemic lymphoma. Overall, these have a very good 5-year survival and 90% progression-free rates. From an exam point of view, conjunctival and ocular adnexal lymphomas are very simple. 95% are B-cell. Most are low-grade marginal zone type lymphomas because the conjunctiva is a malt tissue. If they're going to be high grade, they're most likely a diffuse large B-cell lymphoma. And this is just a good example of what a homogeneous appearing blue cell tumor of the conjunctiva like a lymphoma would look like. And then you can see these monocytoid type cells, often with a Dutcher body as a feature of the dysplastic plasma cells associated with the eventual maturation of these neoplastic cells. Oops. This next case is interesting. It's a patient presenting to the corneal surface in severe eye pain with a corneal ulcer that's been treated with antibiotics and steroids without relief. The patient is a contact lens wearer who tends to overwear their lenses, not like anybody who wears contact lenses in this group would ever overwear them. The diagnosis here is the most feared acanthamoeba keratitis. I bring this up because ocular pathology is not uncommonly involved, because as mentioned here, this is very difficult to diagnose clinically, it's very difficult to treat clinically, and it often comes to either biopsy or a lamellar or full thickness keratoplasty because of the scarring and the inability to get a good diagnosis. There are 2 types, Castellani and polyphagia, depending on where you are. It can be cultured with non-nutrient blood agar layered with E. coli. Now we can do clinicians can do PCR from corneal scrapings, but when it comes down to biopsy, you get these double-walled cysts with the outer exocyst and an inner endocyst. The free form looks almost like a macrophage, about the same size, the trophozoite, and you can pick these up with H&E, as this stain is here, but it also highlights with GMS, PS, or GIMSA. So this is acanthamoeba keratitis. So this is another case that would be very much just the purview of ophthalmic pathology. A general pathologist would never see something like this. Patient presents with decreasing vision in both eyes. Examination reveals an irregularly shaped cornea and significant astigmatism, which means the cornea is very much out of round and very poor vision. And so the diagnosis here is keratoconus. Keratoconus is a bilateral non-inflammatory ectasia or thinning of the central or inferocentral cornea. There's progressive myopia and irregular astigmatism. There's a very interesting association with Downs. One of the etiologies of keratoconus is believed to be eye rubbing. And many patients who have like atopic dermatitis or Down syndrome will spend a lot of time really gouging at their eyes, and that is felt to be a precipitating potential factor in keratoconus. What we see under the microscope is this paracentral thinning or ectasia of the cornea. Bowman's layer is the compressed anterior layer of the stroma that sits just below the epithelium. It serves as a barrier to infectious organisms, to non-scarring erosions of the surface of the eye. Because of the thinning and the pressure applied to the cornea, one will see these buckling or discontinuities in Bowman's. You will get fibrosis because of the progressive thinning. And then, interestingly, there's a thing called a Fleischer ring, which at the base of the cone, because of an accumulation of a tear meniscus, tears containing iron, the iron will deposit in the corneal epithelial cells as a Fleischer ring. So that is an interesting extra feature of keratoconus. So this goes back to my blurred fundus photo at the beginning. This patient presents with blurred vision in both eyes. So it gives a history of floaters, mild light sensitivity. This has been going on for about 3 months. As well, when the patient was seen, the partner said that the behavior's been a little bit off and forgetful and a little bit argumentative, and just not the way the patient used to be. Patient is seen in the ophthalmology clinic. This is the view to the back, which is very blurred due to a vitritis. And this is therefore, by definition, an intermediate uveitis. The patient is tried on steroids, has a workup, doesn't get any better. So eventually the patient comes to a vitrectomy, and the diagnosis is primary vitreoretinal large B-cell lymphoma. So what is primary vitreoretinal large B-cell lymphoma? It's a subset of primary central nervous system lymphoma. Less than 25% of patients with the central nervous system will develop the ocular form, but more than 90% of patients who present with the ocular form go on to develop the CNS form. It's a diffuse large B-cell lymphoma. You will see this in cytology. Again, if you have an institute where there are often vitreoretinal surgeons, they will often send the cassette from the vitrectomy specimen, rule out lymphoma. What you need to look for is a necrotic background. It should be fairly cellular, but the problem with many vitrectomy specimens, they're not. So you have to have a fairly high index of suspicion for these large atypical B cells. Many of these specimens come back as non-diagnostic or mild atypia. It really is a good clinical pathologic correlate. I'm consulted on many of these by my cytology colleagues, and I find the clinical information, discussing it with the uveitis expert or the vitreoretinal surgeon, and I go back and take a look. And my index of suspicion, given those circumstances, will accept some atypical looking cells as being diagnostic. But a classic picture is this one with the necrotic background and the large B cells, which are CD20 positive. The deposits of tumor in an eye that would be enucleated, or if there had to be a retinal biopsy taken, would be under the retinal pigment epithelium and in the subretinal space. That's below the, this is the choroid. This is the sub-RPE space. And then this is the subretinal space. They can extend into the retina and then eventually into the vitreous. The phenotype is that of a post-germinal center B cell, so they're CD10 negative and MUM1 positive, high growth factor, and unfortunately they have a very poor overall prognosis, with not many people living beyond 40 months when diagnosed with this. So this next case is a typically very sad case of a young patient with a white pupil. And we call this leukocoria, which is a white pupil in ambient lighting. So this would be something the pediatrician or whatever would pick up, refer immediately, and the diagnosis is retinoblastoma. A retinoblastoma is the most common childhood intraocular malignancy. The incidence is about 1 in 14,000 to 20,000 live births. The origin is from the primitive nucleated layers of the retina, a neuroblast. You're probably familiar with the RB1 gene, which is the first tumor suppressor gene identified. Its product is a tumor suppressor protein affecting the cell cycle, prolonging the ability of the cell to survive and then proliferate. There's a small group which show a MYC oncogene activation. They're only in 3% of retinoblastomas where the RB1 is negative. All patients who have a retinoblastoma undergo genetic testing because there are germline mutations and a hereditary form which occurs early and occurs in families. And then there's the sporadic, which tends to occur a little bit later. The presentations are most commonly leukocoria, which is a white pupil, and crossed eyes or strabismus due to impairment of the visual axis. So this particular tumor here is, you can see this yellowish area, which is the macula. This poor little patient would not be seeing more than, count fingers or hand movements. And when you lose uniocular input, and therefore you don't have binocular focusing, the eyes will often deviate, ergo strabismus. So, and in the third world, these tumors are picked up, unfortunately, very late. They tend to extend outside the eye and cause massive proptosis. The pathology of retinoblastoma, it's a small, round, blue cell tumor. One can see within the eye here, and it will extend into the choroid. It tends to form these pseudo rosettes where the tumor cells cluster around blood vessels, and after they get to about 110 microns, they lose their blood supply because they need a lot of nutrients to be able to proliferate so quickly, and then they undergo necrosis. And these necrotic areas often calcify, which is very helpful for the ophthalmologist, pediatric ophthalmologist, to make a diagnosis on imaging, because there aren't very many ocular tumors in children that calcify, and retinoblastoma is the prototype. On examinations, especially American boards, they like to talk about the rosette formation in retinoblastoma. There are three classic types of rosettes. The most differentiated is called a fleurette, where you actually see rudimentary outer segments of the photoreceptors, very eosinophilic looking. The next is the Flexner-Wintersteiner, which forms this nice rosette palisade around a central lumen. And the least differentiated is the Homer-Wright, which is just a group of cell nuclei rearranging around neuropil. You see these Homer-Wright rosettes in neuroblastomas, medulloblastomas, but the fleurettes are pretty much only seen in retinoblastomas, but not often. And the Flexner-Wintersteiner can be seen in the other tumors. Interestingly, the degree of rosette formation has no impact on prognosis. The prognosis in retinoblastoma is essentially how far into the optic nerve has it invaded. And interestingly, when I get my specimens from my oculoplastic surgeons for blind painful eyes, they cut the optic nerve at the globe surface. But when I get a globe from an infant for retinoblastoma, they'll give me 4 or 5 centimeters, well, about maybe 4 centimeters of optic nerve, 3 to 4, because the closer the tumor is to the end of the optic nerve, the more likely it's gone into the brain. And if it's gone into the brain, the prognosis is very poor. Other factors would include extension into the anterior chamber, a massive involvement of the choroid, but involvement of the optic nerve still remains one of the most important prognosticators in retinoblastoma. So this patient was noted to have a pigmented lesion on the optic nerve on routine examination. The diagnosis here is melanocytoma or magnocellular nevus. It is a tumor composed of plump polyhedral neval melanocytes. It forms in the optic nerve, uvea, and sclera, most commonly in the optic nerve. Inferotemporal disc, as here, is the most classic location for the tumor. It's usually less than half a disc. It's very common in the African American population in the United States. When it does occur in Caucasians, there is a risk of it undergoing a malignant transformation into a melanoma, Very rarely does it occur in African Americans. 1/3 show signs of growth over 10 years. So growth in and of itself is not an indicator that it is becoming malignant. This is a great picture of that lesion that you saw on the optic nerve, very heavily pigmented. We use bleach to remove the pigment to see the benign morphology of these plump polyhedral nevus cells containing macromelanosomes. So this is a melanocytoma or magnocellular nevus. This patient presents with a gradual onset of blurred vision. The diagnosis is a uveal or choroidal, in this location, melanoma. So this, again, for board writers, this is a very popular examination question relative to ocular pathology. I had to smile when I wrote my anatomic pathology examination. The very first day of the Canadian exams was a 5 out of 7 short answer essay questions we had 2 hours. And so when we go in and we sit down and we get our package, the first question was discuss melanocytic lesions of the eye. And there was this, and you could see there was this massive groan and one person going, yes, we can deal with this. Of course, the second then was the brain tumors, and it just got worse after that. But to show you the way sometimes examiners like to mess with you, I think I definitely passed that part of the exam. General information, disease of people in their 6th and 7th decade, again, slightly more common in men. It is a prototype of a fair complexion, blue-eyed, blonde European descent, but it does occur in all races. The overall incidence is about 5 to 7 per million per year among Caucasians. Predisposing conditions, the congenital ocular or oculodermal melanocytosis, better known as nevus of Oda, which is a blue nevus of cranial nerve 5, showing pigmentation in that particular distribution. There is a 1 in 400 lifetime risk of malignant transformation in Caucasians, not in the Asians and in the African Americans, where this is a more common lesion. The dysplastic nevus syndrome, or familial atypical mole. What's new on the block is the BAP1 tumor disposition syndrome. It's an autosomal dominant due to a germline mutation in the breast-associated protein 1 gene on chromosome 3. Its association with uveal and cutaneous melanomas, renal cell carcinomas, among others. Uveal nevi, the lifetime risk of transformation is about 1 in 400, but it's very age-related. In my ophthalmology practice, I probably would see 1 or 2 choroidal nevi a month, and in my pathology practice, maybe 1 choroidal melanoma a year, give or take. And then neurofibromatosis is also a predisposing factor. So the uveal melanomas can occur in the iris as an iris melanoma. I won't talk about those. Ciliary body, which we call a ciliary body melanoma. And then in the choroid as a choroidal melanoma. The ciliary body melanomas are interesting. They're often round. They tend to become quite large because they're tucked off to the side and relatively asymptomatic. When quite large, they'll indent the lens and cause a cataract. They can be associated with an overlying retinal detachment. They are often dome-shaped, mushroom-shaped if there's a particular part of the choroid called Brooks membrane, and that lies right in conjunction with the retinal pigment epithelium, the differentiating area between the choroid and the retina. It's a very fibrous membrane. As the tumor grows, it can actually rupture Brooks membrane, and it causes this little bit of an indentation, to make it look like a mushroom. And then there's the diffuse type. The cell types in uveal melanoma, some great work done by a pathologist Calendar many years ago. There are 2 basic types, spindle and epithelioid. The spindle are divided into spindle A and spindle B. Spindle A has this nice nuclear groove, and spindle B has a nucleolus. The epithelioid cells are discohesive. They have distinct borders, abundant cytoplasm, much larger than the spindle B. It's important that when we get these tumors to describe what kind of cell morphology there is, because the 2 most important histopathologic factors in uveal melanoma is tumor cell type and tumor size. So the AJCC grades the tumors. Grade 1 is a spindle tumor with greater than 90% spindle cells, mostly spindle B. Epithelioid is grade 3, which is more than 90% epithelioid cells. And then the large majority of uveal melanomas are mixed or grade 2, which is greater than 10% epithelioid and less than 90% spindle cells. So it's got a mixture of both. And the prognosis is good for a spindle, intermediate for mixed, and poor for epithelioid. The size of the tumor in contact with the sclera, that's why when I was talking about how we section these using transillumination, important to get the maximum height and the maximum basal diameter, because we use this chart right here to grade from a small tumor, which is T1, to an extra large tumor, which is T4. The latest advance in uveal melanomas is the genetic profile, and uveal melanomas are unlike cutaneous and conjunctival melanomas, both which show the BRAF and NRAS mutations. The genetic profile of uveal melanoma is like blue nevi, with GNA11 and GNAQ driving mutations. They are seen in more than 90%. Additional chromosomal abnormalities such as monosomy 3 and trisomy 8 have a very good predictive value of metastasis and poor prognosis. We now clinically use gene expression profile on tumor samples looking at RNA, and we can classify them into class 1 and class 2. Class 1 is a low-grade tumor, rarely metastasizes, has a genetic profile like aNEVIS, and has a very good prognosis. But we've now been able to subdivide it according to its PRAME expression. And you're all familiar with PRAME, I'm sure, the preferentially expressed antigen in melanoma, which is used in dermatopathology more and more for helping to diagnose melanomas. If it's PRAME negative, it's got a very low risk of metastasis. If it's PRAME positive, it's got a moderate risk. And then if it's class 2, it's got a 90% risk of metastasis, and 84% of these have an inactivation in the BAP1 genome. Again, this is just to show you the spectrum and the evolution of the management and the advances in uveal melanoma. So this patient presents with double vision for 6 months, gradually getting worse. On examination, you can see the right globe is displaced down and in. The diagnosis is adenoid cystic carcinoma. Adenoid cystic carcinoma is an epithelial malignancy of the lacrimal gland. It occurs in 2 age groups, usually adults over the age of 40, rarely in children. Interesting, when it occurs in children, mid to late teens, it has a pretty good prognosis, whereas it occurs in an adult, it's a pretty dismal prognosis. The recurrence rates are as high as 75%. The 15-year survival is still only 46%. You're familiar with the histology is in a minor salivary gland, most common neoplasm, with a cribriform glandular architectural pattern, so-called Swiss cheese. The more diffuse or solid it is, the worse the prognosis, and it's very notorious for its prominent perineural invasion. This young patient presents with left globe proptosis, eyes bulged out, and dystopia, meaning the eye is displaced down, and the diagnosis is an orbital rhabdomyosarcoma. The orbital rhabdomyosarcoma is see if I can get back to my next, there we go, is the most common primary orbital malignancy in childhood. The average age is 6 to 8 years. Most are younger than 10. It occurs in the supranasal orbit. There are 2 basic types for ophthalmic pathology. Embryonal is the most common. It occurs in younger children. It's got the biphasic hypercellular, hypocellular areas. You've got the rhabdomyoblasts in a myxoid stroma. You'll get the tadpole cells. Immunohistochemistry, it's positive for myoglobin, myogenin. Interestingly, the embryonal form shows a heterogeneous variable staining for myogenin, which is a tip-off. All of these go to genetic studies because embryonal is fusion negative. Oops. The second type that occurs in the orbit is alveolar. It occurs in the inferior orbit, slightly older children. You have the fibrous septa with tumor cells floating off into it like into an alveolar space. It shows strong myogenin staining as opposed to embryonal. It's fusion positive. The fusion partners are either FOX01 PAX3 or FOX01 PAX7. The importance of fusion status in rhabdomyosarcoma cannot be overstated, because the prognosis is based on fusion status. If it's fusion negative, even if it looks alveolar, it's got a good prognosis, and it usually doesn't go to radiotherapy. If it's fusion, that's a fusion negative. If it's fusion positive, even if it looks embryonal, it is treated as an alveolar type, which has a worse prognosis and often goes to radiotherapy. And unfortunately, radiation in children in the orbital area can have devastating consequences, lack of orbital growth and other problems. So it's very important to use the fusion status in rhabdomyosarcoma. Now, this patient presents for a routine examination, and in the course of the exam, the ophthalmologist noted an asymmetry in the cup to disc ratio, with small on the right and large on the left, suspicious for glaucoma. But because there was evidence of other abnormalities, despite good vision, like color being gone, suggested an optic neuropathy, a CT scan was arranged, and this patient has a optic nerve sheath meningioma. Its average age is 38, more common in women. It's associated with neurofibromatosis 2, especially when it presents in young children. The majority are WHO grade 1, meningothelial or transitional. You know, the EMA, the positivity for EMA and SSTR2A is characteristic of meningioma. But this is another thing that the ophthalmologist will diagnose clinically, and then a biopsy will often be done to ensure that it is not something different. So that's an optic nerve sheath meningioma.
Could I just jump in, Dr. Farmer?
Yeah.
We just sort of conscious of the time, and the students and residents would have many, many questions for you.
Perfect.
So, yeah.
Why don't we move right to, because this last case, I don't think it's very common in the Caribbean, because I gave this talk once at a Caribbean ophthalmology meeting in giant cell arteritis, my favorite topic, but we could talk about that later. Finally, I'll just say, if you're interested in ophthalmic pathology, the fellowship is typically a year. You would do it in a hospital that has got a strong ocular pathology department, such as the Wills Eye Hospital in Philadelphia, Johns Hopkins in Baltimore, Baskin Palmer in the University of Miami, Mass General at Harvard. In Canada, the place that would offer it would be McGill University, where they actually offer research fellowships as well as a master's and a PhD program. So I think ophthalmic pathology is a very rewarding career. I've enjoyed my 38 plus years of ophthalmology and pathology, and continue to be impressed and learned and thrilled by every case I see every day. So I'm open for business for talk.
Great. Thank you so much, Dr. Farmer. So I'll just read off a couple of questions that we have. The first one is, how popular is ophthalmic pathology amongst the subspecialties?
That's a very, very good question. In centers with ophthalmology programs, it's essential. I spend a good portion of my time teaching ophthalmic pathology to both the ophthalmology residents and the anatomic pathology residents. Indeed, I'm part of this Toronto ophthalmology review course that's given in Toronto, and I think we actually get some people from ophthalmology residents from the West Indies to come up for the course. I teach ophthalmic pathology to all ophthalmology residents across Canada in their second year of residency in ophthalmology. But it's also important in the Royal College now in pathology to recognize ophthalmic pathology as a specialty. I think when I get residents rotate through ophthalmic pathology, they see the cases and they see the enthusiasm that myself and I have a colleague, Kianish Kianian in Ottawa, to have. It's a very, I think people become very interested in it, because it's also nice because we know our clinicians. It's very great. It's a great ClinPath correlate, a lot like dermatopathology.
Okay, thank you. And I know it was mentioned there just now, but what postgraduate training would you advise for those of us who are interested in ophthalmic pathology? Well,
this is a very good question. To put it simply, many pathology departments, especially associated with ophthalmology programs, need an ophthalmic pathologist. if you were going to be a more high-powered academic ophthalmic pathologist, especially if you were going to practice, let's say, in the United States, and it would be a bonus in Canada, but not, you really need certification in both ophthalmology and anatomic pathology and a year in ophthalmic pathology. That happens in the United States because of the academic milieu that they're in. In Canada, Miguel Bernier in Montreal and myself are the only two double-boarded ophthalmologists, anatomic pathologists in Canada. Most of my colleagues in the Ophthalmic Pathology Society are anatomic pathologists who have picked up ophthalmic pathology as an interest during their residency and then have found a mentor. There used to be Val White, who's now retired. She was in University of BC, who was a very good one. And then people have also had worked with Dr. Bernier in Montreal. So if you want to contribute to an anatomic pathology program, then doing a fellowship in one of those institutions for 6 months to a year would be more than qualify you for the ability to practice good ophthalmic pathology.
Okay, great. And are there any joint neuropathology, ophthalmic pathology fellowships?
I would suggest, if there would be, I would certainly recommend Johns Hopkins because, again, traditionally, ophthalmic pathology was done by neuropathologists, if there wasn't an ophthalmic pathologist there, or it was divided up into all those subspecialties that I tried to highlight with all my cases. So neuropathology, because the eye is part of the brain, felt to be a logical connection. Two of my colleagues in the Eastern Ophthalmic Pathology Society, well, many of them actually are neuropathologists. Our guest speaker, now I'm thinking about it, in June is Thomas Cummings. He's a neuropathologist, ophthalmic pathologist from Duke. And Charles Eberhardt, who's a neuropathologist, ophthalmic pathologist from Johns Hopkins, has also attended one of our meetings. Both of those institutions, I'm sure, would end up offering a fellowship in neuropathology. And if you were part of their department, they would take ophthalmic pathology as a second logic. But those need to be arranged per institution. There isn't a matching service or matching positions for ophthalmic pathology. It's more informal. Okay.
So in pediatric forensic pathology, non-accidental head injury can be associated with the retinal hemorrhages, right? But
that's correct.
These are considered non-specific for inflicted head injury. So should ophthalmic pathologists or forensic neuropathologists examine the excised eyes in these cases?
Oh, absolutely. I have been involved in a couple of cases many, many years ago with our strong forensic unit. Now, I don't think they rely on us as much, but absolutely. It was at one time felt that the hemorrhagic foveal retinoschisis was diagnostic of non-accidental trauma. And unfortunately, there were a number of cases where this was felt to be the diagnosis, but it's now been proven that it can occur in accidental trauma. So there's nothing that is pathognomonic, but seeing subarachnoid hemorrhages around the optic nerve, extensive hemorrhages within the retina, and a hemorrhagic foveal retinoschisis is strong supportive evidence. And I would defer to Dr. Walker in their case to build for these circumstances. But unfortunately, they should be examined by an ophthalmologist, an ophthalmic pathologist, or somebody with expertise in looking at globes.
Okay, great. So someone is asking if there are any observerships for approximately 2 months or so that are available in ophthalmic pathology. Any that you know of?
Again, per se, I would say not necessarily, but again, the list of people that I've given, I think do take residents for shorter periods of time. I mean, I've had occasional residents come to Ottawa when I was actually working there more than now, and they would spend a month with me and get a good survey of it. But again, it is possible to do it, and again, it would be arranged on a request basis for the place that one might want to go. So if one wanted to go to, as I said, Johns Hopkins, it'd be Dr. Eberhard. At Duke, it'd be Tom Cummings. I mean, you know, and again, if somebody was really interested in something like that, I wouldn't mind. I could act as a bit of a facilitator just to see if, again, depending on their schedules and whatever, if they could accommodate. But most of us are pretty keen as pathologists if somebody shows an interest in a subspecialty to want to highlight it.
Okay, great. If anyone has any more questions, you could put us in the chat, or you could unmute your mic now. We'll just give them a couple seconds. I'm not seeing anything right now. If there are any further questions that are sent to me after, I guess I can always just email you and disseminate the answers.
Yes.
So we have a Menti feedback form that I'd like the participants to just click on and give some feedback, so Dr. Farmer could have some live feedback while we're here. So you could go ahead and fill that out. I'll just share the results.
Do you, just out of curiosity, Vanessa, do you get exposure to ophthalmic pathology during your residency in pathology?
The only exposure that we've had so far would have been in year 3 when we had anatomical pathology, and I can tell you, no, we did not have much exposure at all. So that's why these talks are very much welcomed.
How many?
So if I could just jump in here, James.
Yep.
So the only established postgraduate residency program in anatomical pathology in the Caribbean exists at the University of the West Indies, Mona, Jamaica campus. And recently, my alma mater, the St. Augustine campus in Trinidad and Tobago, started a residency program. I think it's in its first year. So there, as far as postgraduate training in anatomical pathology in the Caribbean is concerned, UWI Mona has a longer, better established history, and then medical graduates of Cuban universities can also pursue postgraduate training in anatomical pathology in Cuba. Mm-hmm. So the exposure to ophthalmic pathology is limited, both at the medical student level, which is where Vanessa and most of the people on this call are at, mm-hmm. And even less so for postgraduates, because they're only in the English-speaking Caribbean. There are 2 programs. One has a much longer history, started in 1974, versus the more recently established one.
Okay, good. I see there's another question, and it says, could practicing pathologists also be allowed observerships? And I think the answer is yes as well. Again, on an individualized basis, but most of the colleagues that I deal with in ophthalmic pathology are very, very nice people, and they're very interested in teaching. They're very interested in sharing information and whatever. So I would be willing to bet the answer is pretty much there would be people who would be willing to do that.
Okay, great. So these are just some live feedback from everyone who participated. Some thought it was inspirational, it was very interesting, eye-opening, awe-inspiring, informative, fantastic. So we have a wide range of wonderful things that everybody has said about you.
Well, that's very kind. Thank you very much. It's my privilege to be able to talk and hopefully maybe inspire a few people to be consider it as something to do.
Yes. So now I'd like to deliver the vote of thanks, or sorry, Dr. Walker, I'm sorry to put you on the spot, but would you like to say anything as you're here?
So as a colleague of Dr. Farmer for the last 12 years, just being in his presence professionally, has been, one of the advantages of being in this department. As he indicated, his he's a member of a very unique group of subspecialty pathologists in Canada. And I always welcome, our interactions, social and professional in the department. And I just want to tell him thank you from the bottom of my heart for accepting this invitation on behalf of the Pathology Club to speak today. So I'll hand it back over to you. Thank you, James.
Great.
Thank you.
You're very welcome. It's been my pleasure.
Okay, great. So I hope that everyone here had a wonderful time as well as a great learning experience, especially with all those cases. So at this time, the feedback form link has been sent and we would like you to just take a minute to fill it out. We will greatly appreciate this for not only documentation, but to be able to improve our future events. So firstly, I'd like to thank you, Dr. Farmer, our feature speaker, who, despite your busy schedule, has graced us this evening with an amazing, very detailed and thorough, enlightening presentation, where we were extremely grateful to learn about ophthalmic pathology. We are most happy that you were able to give us an insight into this, I would say, niche subspecialty of pathology. And we are hopeful that the audience members were able to take pertinent notes and just see how important this specialty is. I'd also like to extend gratitude to Dr. Alfredo Walker and Dr. Catherine Morris, our advisory board members. Thank you, Dr. Walker, for also gracing us with your presence this evening. We appreciate the endless support from them. Like I said, they are our advisory board members. And I mentioned earlier, this is actually our 23rd session of CPALMSI, and it's the last one for this academic year. So we've come quite a long way. We have quite a ways to go as well, but this would be our 3rd successful year in operation. So we thank you all for your very valuable time, effort, and consideration in the investment in the future of pathology. It is not only an act of success, but one of greatness for showing us the paths that you all have walked on. So I'd like to leave you all with a quote: "Smooth sea never made a skilled sailor." Everyone has their ups and downs. So like I say, we have a long way to go, but we are making great strides. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success. And we do look forward to your continued support in the future. To all of our UE students and staff across the 3 campuses at the University of Ottawa and Eastern Ontario Laboratory Regional Association, and especially to our specially invited guests, thank you, thank you, thank you from the bottom of my heart. So ladies and gentlemen, this marks the end of our session this evening. Thank you very much and have a good night.
Okay, before everyone signs out, I just want to say this is the end of the 3rd consecutive year of this initiative, which started in the middle of the COVID-19 pandemic, August 2020, by 7 medical students at the UWI St. Augustine, Trinidad and Tobago campus in very trying times. This is the 23rd edition, and subsequent to us starting the CPALMSI sessions in August 2020, the National Association of Medical Examiners, which is the professional body of forensic pathologists in the United States, mirrored this initiative as a means of attracting medical student recruitment into pathology. And they are now at their 19th monthly session, and we are on our 23rd. And this is all down to the efforts of the medical students. The current president, Vanessa Ramsaran, who has taken on the mantle from Ranjiva, who was president last year, who took the baton from now Dr. Anne-Marie Minghon, who was the founding president. I honestly do not know where you all find time to do this to the standard at which you do it. I certainly would not have had the time back in the day. So on behalf of the Department of Pathology and Laboratory Medicine at the University of Ottawa, the cumulative audience, I want to say thank you to the executive of the Pathology Club of the University of the West Indies for taking on this, what is essentially a burden, you know, trying to juggle clinical, you know, clerkships. Vanessa is in her last month of fourth-year medical school, about to enter final year. So finding the time to do this. So thank you all very much. And I hope that in the long run, you derive the benefits from your investment. So I just wanted to point that out to you all.
Okay, thank you so much. Okay, bye everyone.
Bye-bye. Thank you.